Welcome to Ask Dr. Mingle, a Q&A series from Mingle Health where we take your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and executive chairman of Mingle Health.
Good morning, Kyle, and good day to all of you tuning in. Great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Before we get into today's questions, I want to invite our listeners to send us their questions for Dr. Mingle. You can leave your questions in a comment on LinkedIn or YouTube, and you can email them directly to us at hello@minglehealth.com. And with that out of the way, let's jump into today's questions. Are you ready, Dr. Mingle?
I'm ready, Kyle. Bring them on.
Our first question today is from Danielle. And Danielle asks, can you explain data completeness? Is it 70% of the denominator? CMS says if reporting CQM or ECQM, we need 100% of data.
Well, great question, Danielle. I can see some of the root of the confusion there. I'm not sure where the quote of needing 100% of the data comes from. I know part of the logic of Medicare is that if you get your data directly from an EHR, that they assume you've got 100%. Now, that's not exactly the data completeness criteria. So let me just start with the data completeness criteria. So the requirement this year is 70% of the denominator. And in the proposed rule that's now out, they're looking to increase that to 75, I think 2 years from now. And it's useful to remember that you need to have an accurate denominator. It's only by knowing what your denominator is that you know if you have 50%, 70%, or 100% of the data. Or let me say, it's really not of the data so much as it's of the denominator. The denominator represents patients who are eligible for the measure, or it represents encounters. Off the top of my head, I can't remember any other thing that the denominator counts. So once you've determined the denominator, you need to need to assess at least 70% of those instances in the numerator. So you have to have numerator data on at least 70% of the denominator. So it's easy to think of your patient panel. If you have 100 patients who are eligible for a particular measure, you have to report on at least 70% of them to have the data completeness in Medicare. Now, if all your patients are at a single EHR, that's where Medicare assumes you've got 100% of the data. And if you're getting data directly from the EHR, missing data is assumed to be performance not met. Whereas if you're getting your data from some other source, or if you're working with multiple EHRs, bringing all that data together, or if you're working from a tumor registry or a diabetes registry or any other kind of registry that's a derivative of EHR or even independently built alongside EHR, then missing data becomes not reported instead of not performed. Again, having that combined data set that you know what your denominator is important, and we find that to be an easier data set to access. We find it relatively. The gold standard to measure the denominator for any measure comes from your practice management system or your claims. So it's the occasion of a visit for that patient by the provider or the provider's practice that creates a denominator instance. And everyone, in my experience, is submitting claims. Well, of course they're submitting claims. It's the only way you get paid. And claims 99% of the time go through a claims clearinghouse, and there's a standard data set that goes there. We tap into that data set. We bring the data into our system, assess. It's a first pass assessment of denominators. It's not perfect, but it's good. And it is a great standard by which to measure that 70%. Hope that helps.
Yeah, great question, Danielle. Okay, our second and last question today is from Rick. And Rick asks, our providers don't admit patients. We make rounds at hospitals, so we don't have answers to quality items for those patients. How can we meet the 75-point minimum in MIPS?
Thanks, Kyle, and Rick. Thanks for the great question. This is an interesting puzzle, and a lot of my specialty and subspecialty friends and our clients run into this issue. So I will take a little bit of extra time to dig into it. In MIPS, you're expected to do your best to find 6 measures there. Um, in like some of the APMs, it's not 6. Certainly, the APP is 3. But let's just qualitatively, it's the same answer when we talk about the MIPS and 6 measures. Now, there are plenty of providers who have no applicable measures, and a lot that have 6, and a lot that have even fewer. There are a handful of relatively straightforward exceptions you might qualify for. So you want to start by looking for those exceptions. Um, uh, it's useful to remember there are specialty measure sets. You should look at those measure sets. Um, uh, of course, there are about 200, and there's more than 250 specialties if you look at the NUCC specialty taxonomy codes. Medicare consolidates that and sorts it into approximately 30 different specialties. And of course, there's measure sets for only a fraction of those, maybe close to half at this point. So even though there may be a specialty measure set, your particular approach to your specialty may not make you eligible for any of those measures. But that's a good place to start. Medicare says that if you match your specialty to one of theirs, and you submit everything um, from that measure set, you've satisfied their requirements. Um, Now, if many of those measure sets have more than 6 measures, uh, and you don't have to submit more than 6, a few of those measure sets have fewer than 6 measures, and submitting a complete set makes it a complete submission, and you're not required to submit any more to get a full score. So a lot of times, even though you're matching specialties, the peculiarities or the particulars of your practice makes it impossible for you to submit some of those measures. You just don't generate the data to submit those measures. So it's an automatic and easy answer to that. That if you high quality analysis of your data shows that you have no denominators, you have no eligible instances for those measures, submitting a 0 numerator over a 0 denominator is a valid approach to those, and basically they back that out of your score. You'll get credit for anything that you're able to submit, and credit that you tried with those others. And therefore they forgive and adjust the score accordingly. Now, you can fill out your 6 measures by going with a QCDR, a Qualified Clinical Data Registry. A lot of specialties now have a QCDR, but you're not required to go in that direction to fill out your 6 measures. You can, but you don't have to. You can submit data that you didn't generate. So if you're, for instance, an endocrinologist and submitting about diabetics, and uh, some of the data is some of the hemoglobin A1C data is generated from the by the people uh, whose referrals you're taking. Um, it is Medicare recognizes and supports and encourages us to work as teams. So submitting their data is perfectly valid. Um, the same thing with say flu shots. If you're doing the flu shot measure, you never give flu shots, but you ask about the flu status, um, or even just get the flu status and from a shared record with other people. That is legitimate. A little harder uh, to support long term, but frankly, with the group practice reporting option and those dynamics, if you have the data and submit it, that's fine. You're not going to get as high a score if you're always going off of someone else's data, because you'll see some patients who don't come through that workflow. But again, with a team care in healthcare, that is a legitimate way to get to your data. Consider facility-based quality options. If you if 75% of your charges are in a hospital setting, and that includes the hospital outpatient department, the emergency room, the inpatient unit, you qualify for facility-based submission. If if the hospital you're working in has a hospital value-based purchasing program quality submission, you can tap into that. And if you are qualified for facility based, but your hospital doesn't have a submission, that you can't take advantage of that. Now Medicare tracks that. It's available on the qbp.cms.gov website, and you can put in your NPI and see what your current status is about facility based. It'll tell you whether or not you qualify, what facility you're assigned to based on volume, and whether or not that facility has a value based submission that you can take advantage of. Consider the eligible measure applicability test. Medicare has put together this analysis called EMA, eligible measure applicability. It starts with specialty measure sets. Basically saying what I told you earlier, that if you submit everything you can submit out of the specialty measure set, that's a complete submission. But it also has a portion of it that's around clinically related measures. And if you submit any single measure, they'll look at those clinically related measures and assume that you should have been able to submit any other measure in that clinical set. Um, and again, the way to handle that is if you can't, if you don't have, if you don't do the work, don't have the data, then uh, don't have patients eligible for it, then a 0/0 submission uh, counts towards your one of those six measures and doesn't hurt your scoring. Um, Prospectively, you can consider applying for a hardship exception. This is a good option before Medicare. You can submit an application now explaining your situation and the lack of measures, and you'll get a read on that before the submission period, and know going into it what your requirements are. After the fact, you can apply for a targeted review. And I don't recommend you count on that, because it's too late then if you get a negative response to that request to make another submission or take other action. But if you did your best, you get to the submission season, you have a Medicare judges it inadequate and counts you down, then you do have that option of requesting a targeted review. The biggest issue, I think, is there's a lot of people who fall between the rules. That Medicare's submission specifications or measure specifications include relatively standard CPT or what they call HCPCS codes, your procedure codes, and ICD codes. And you often have patients that qualify for measure by those specs, um, but for care that you don't provide. And that's the toughest thing, because that gets to judgment. Then you don't have a clean zero denominator that you can submit to Medicare. You end up having a denominator in which you can't submit numerator. That's where you need the most explanation. That's a time when you want to submit a hardship application outlining the reasons why you can't do those measures and get a ruling before submission season. Now, with all of the complexity of the places you can look for measures, your eligibility for it, it's a good reason to engage a group like ours. We'll take your claims data. We'll do an initial measurement of all of the measures that you're eligible for, based on the CPT and ICD codes, sex and age of the patients in that data set. We can go over that to understand the scope of your practice, and where scope of practice rules out some of them, and a plan to support your decision and your submission to Medicare. It may be just as important to submit your lack of measures as it is to submit your measures when it comes to your MIPS scoring. There's a couple places where you can run into trouble with it. One is the initial submission, where Medicare, or the request for an exception, or your submission of 0 over 0. Medicare might disagree with any of those and just deny it to begin with. Then, if they accept it, you can be audited. And you have to have your data together to survive audit, so that you can justify the decision that you made and the submission you made, and then get and maintain that through Medicare. I think that covers most everything. It's it's not a straightforward analysis, a lot of things to think about, and we're delighted to help you if we can. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.